All right, well, good morning, everybody. I'm gonna go ahead and get started. My name is Ashley Craiglow. My pronouns are she, her. For a physical description, I am a female with brown shoulder length hair that is up in a clip today, and I am wearing glasses and a gray sweater. And I am with the Arrowhead Area Agency on Aging, and I'd like to welcome and thank you for joining us for today's session on Medicare Changes for Open Enrollment 2024. So before we start, a few housekeeping items. We are excited to announce that today's webinar will be accessible to a wider audience. We have arranged for American Sign Language interpreters who will be present throughout the session. These interpreters will rotate every 20 minutes, ensuring that everyone can follow the content effectively. Additionally, we are recording the entire webinar with ASL interpretation. The recordings will be available on our YouTube channel for later viewing. Whether you attend the live session or catch up later, you'll have the opportunity to engage with the material in a way that suits your needs. I encourage you to subscribe to our YouTube channel so that you can keep up with the latest additions to our video library. We are always looking for suggestions for future webinar topics, so if you have anything that you are interested in, please feel free to send me an email or share in the chat. Please keep your microphone set to mute, and just note that if you are experiencing any issues with bandwidth or audio quality, it often helps to disable your camera. If you would like, you can enter your first name, and if you're with an organization or from a community, you can enter that into the chat as well, and then what you're hoping to get out of today's session and how you found out about us. If you have any questions during today's session, please enter your question into the chat, and we will address them at the end of the presentation if we have time. And if not, I can definitely email you back with the responses from Marjorie at that time. And then at the close of today's session, you will see a quick evaluation of today's session pop up in your browser. So if you could take a minute and complete that survey, it greatly helps us for planning future webinars. And then one last quick reminder is just to visit our Facebook page for more information about other upcoming sessions. You can also check out our website out at arrowheadaging.org, and I can put that in the chat when I am done here. So a little bit about the Arrowhead Area Agency on Aging. The Arrowhead Regional Development Commission is designated by the Minnesota Board on Aging as the Area Agency on Aging for Planning and Service Area under the authority of Title III of the Older Americans Act. The Arrowhead Area Agency on Aging is committed to helping older adults maintain their highest level of independence. Triple A's are regional organizations across the state that provide services and supports and information for just about anything and everything that older adults and their families could need. Minnesota has 7 Triple A's across the state that are local connections to older Minnesotans and the community support they need as they age. The Arrowhead Area Agency on Aging's planning and service area, as designated by the Board on Aging, includes the counties Aiken, Carlton, Cook, Itasca, Koochiching, Lake, and St. Louis. So I'm just going to take a minute to read our Arrowhead Area Agency on Aging's land acknowledgement. As we support our mission to help older adults maintain their highest level of independence, we do this while being respectful of the space we are being welcomed into by Indigenous people. We strive to deepen our understanding of the multiple ways in which people see and understand land and acknowledge the Indigenous people who have relationships in this land. We also acknowledge the decades of historical trauma, loss, and grief experienced by Indigenous people. It is our promise not only recognize these truths, but also take action to show support of our Indigenous elders, neighbors, and friends, and understand our place within the past, present, and future of this land. We know this is just one step in recognizing and honoring the sovereignty of tribal nations. So I am honored to be joined by our presenter today, Marjorie. Marjorie serves as a contact center manager for the Arrowhead Regional Development Commission's Area Agency on Aging. She and 18 senior linkage line team members provide long-term care options, counseling, information assistance, and referral, education, outreach, and advocacy on Medicare, health and long-term care options, local, federal, and state programs through the Senior Linkage Line Service. The Senior Linkage Line Service also connects Minnesotans of any age to patient assistance programs that help with the cost of expensive prescriptions, performs pre-admission screens for nursing home admission, and live at home support, including caregiver support. Marjorie has a BA in organizational behavior from the College of St. Scholastica, certificates in aging and care transitions from Boston University's School of Geriatric Social Work, and is a certified state health insurance and assistance program counselor. So thank you, Marjorie, for joining me today, and I'm going to now turn things over to you.
Thanks, Ashley. So thank you for everyone for taking time out of your day. There definitely will and should be time at the end for your questions. The only question right now is whether or not I'll be able to answer them or whether I'll have to send you information. Uh, Things are changing a lot. A lot of the Medicare information for 2025, like premiums and deductibles, are not even out here yet for sure. So those weren't the things we were really going to focus in on. This is just a honed down version of some of the most important 2025 updates to Medicare. It's coming from, either Inflation Reduction Act or other pieces of legislation out there. Slide, please. So first, we just want to remind you that we have just started Medicare's open enrollment. Annual open enrollment runs from October 15th through December 7th of each year. This is the time of year that Medicare beneficiaries can switch plans for the upcoming year, with those new plans going into effect January 1st. Also, around this time of year, each plan sends out a statement called an annual notice of change, so an ANOC. It's really important that Medicare beneficiaries review these statements and these packets of information. Oftentimes we don't, we just kind of put it aside as junk mail, but these ANOC or annual notices of change tell everything about a Medicare beneficiary's current plan and what is going to be changing in the upcoming year. So,
Marjorie, I hate to interrupt you, but they're having a hard time with your like hearing you over the speaker.
okay,
Just sounds a little bit muffled.
okay, is it any better? Any better at all?
Little bit.
How about now?
There you go. That sounds much better.
Okay, great. All right, do I need to repeat anything or are we good there? Can we get thumbs up or anybody in chat letting us know? So what I was talking about was the annual notice of change that gets sent out by each plan each year to all of their Medicare beneficiaries, and the importance of reviewing that notice of change statement or packet. It's going to have information about cost changes, changes to copays and insurance, premiums, really importantly, formulary changes. So is your drug that you've been getting through this plan all of this year still covered, or is it covered at a much higher cost? Plan network changes are, which doctors and providers are network in the plan's network. Going outside of the network almost always means paying more than staying inside of a plan's network of providers. So these again are really important things that should help people decide whether or not they want to review other plan options and or switch plans for the new year. That decision can be a big cost savings decision for people. So things to consider. I just mentioned some of those things, but when comparing and considering plan options, what does the plan cover versus, say, original Medicare? A lot of people are in what we call Medicare Advantage plans, which covers the hospital health and the drug coverage all under one roof. And is that plan covering well? What are my out of pocket costs going to be in the new year? What are my copays going to be? Do I see a general practitioner once a year, or do I see a specialist once every 3 months? What will that cost me? What are my out of pocket costs again? Are my providers again in the plan's network? Am I a snowbird? Do I go live in Texas or Arizona for several months a year? What does that mean with my current plan? What do I pay in this other state? Um, uh, what do I do if a service is not covered? Always check, I guess, with the plan first. Um, Sometimes when a plan is or a service is not covered, it's just a mistake, a billing error, a coding error. So we always say check with the plan first before you think about trying to go to the appeal level to appeal something that wasn't paid for. It is often just human error. It can happen. There's just so many Medicare billing codes out there to use, and so not many more ways to maybe make a mistake when submitting a claim for payment. Anyway, if that's the case, the provider can resubmit the claim and hopefully things will be paid and you're on your merry way. Um, if pursuing an appeal, instructions are usually on the back of the denial letter that Medicare sends or the plan sends, and senior linkage line specialists can help people with appeals process because it can be difficult and kind of complex. So specialists are here to help the senior linkage line with that. Other things to consider is, does the plan have supplemental benefits? So like fitness, nutrition, hearing, dental, um, payment towards out over the counter medications. So a lot of plans have these, again, supplemental benefits. You won't necessarily see that right up front, but that can mean the difference and help you make that decision as to whether you would like to move to that plan or switch to that plan or not. Um, and then, of course, what is my responsibility as a plan enrollee? What do I pay? So the next slide. One of the changes taking place in 2025, and this happens a lot with Medicare products and their website and things that they send out, but they and the plans are looking to improve the legibility and readability and understandability of these statements that are coming to people's homes. So that's been an issue, ongoing issue for folks. So always looking for ways to improve that and make it more understandable and improve the clarity of these mailings to folks. They still have to read them when they get them, but yeah, so that's a change, and we do see this happening a lot each year with Medicare, either on their Medicare.gov website or with their mailings to their enrollees. And the next slide. Another disturbing thing that we're noticing, and especially in the last couple of months, is more and more of our Minnesota healthcare systems have announced that they will be discontinuing working with certain health plans. Um, these are some of the health systems that we're already aware of in 2025. So doctors in these systems and these clinics and hospitals are saying, no to certain health plans. Vera Health is leaving Humana. Essentia Health, which is certainly in our region in northeastern Minnesota, is leaving Humana and United Healthcare. Fairview Healthcare System is leaving Humana. Health Partners is leaving United Healthcare. Sanford Health is leaving Humana. North Memorial Hospital is leaving Humana. Um, Minnesota Health Fairview is leaving Allina and Allina Aetna. Most people will not want to leave their current provider. As you can, you've established these relationships with your providers. That's not what we want to do. So finding a new health plan is probably the more likely thing that somebody's going to want to do. Always checking every year with your provider is a good idea. You know, are you still in the network? Those types of things. Because you might be riding for many, many years with a plan and be stable. But again, these things can change, and these things are sent out. And that notice of change gets sent out every fall to um, plan enrollees. So very important. One of the questions you might ask here at the end is why? Um, there's just a myriad of reasons, but one typical reason might be just ease of use for that healthcare provider. That provider might be, or that health insurance plan might be providing good coverage. The enrollee themselves might be happy, but sometimes there's issues with claim submissions and response time, things like that. So those are just some of the reasons that some of these healthcare systems might be discontinuing using some of these health insurance companies in 2025. Right, next slide. So what can we do when this happens? We can join another Medicare Advantage plan or Medicare drug plan. Um, in Minnesota, we still have some counties that also work with cost plans, so that might be an option too. Um, Switch from your Medicare Advantage plan to another plan. That's one of the things we can do again. You'll be enrolled into Original Medicare if you do nothing. So you can go back to Original Medicare and enroll in a Medicare Part D plan. But again, if you do nothing, you're just going to be back to Original Medicare Part A and B and have some higher deductibles, copays, and out of pocket costs. When you can make these changes is now. So October 15th through December 7th, if you're wanting to make a change to your plan. There's also what we call a special enrollment period for health plans that actually just leave the system altogether. So that's another period that Medicare beneficiaries can make some changes. These special enrollment periods again only exist when a plan is leaving an area, like a county or a state, or terminating altogether. These special enrollment periods are there again to provide other options for folks to consider Medicare Advantage plans or going back to original Medicare, potentially getting into a cost plan if they have cost plans available in the county that they live in. So yeah, this is the time of year that we make those changes. So right now, everybody should be probably double checking with their current plans to see if their providers are still in their network and what that would mean cost wise for them. Next slide. So everybody may remember the term donut hole. That's gone. We now have just these deductible initial cover pieces that there's no donut hole anymore. We just have no uncovered period of time with our Medicare Part D. So if you're in a Part D plan, a private pay Part D plan, the enrollee pays 100% until their deductible is met. Could this change from plan to plan? Yes, because some plans offer um, certain tiered meds right away without needing to meet the deductible. But again, that's all stuff that Senior Linkage Line can help folks with if you want to look at what your plan options are and what makes most sense to you depending on what medications you're taking. You can also go directly to Medicare.gov and look this up yourself or call Medicare. Um, Deductibles for Medicare Part D in 2025 cannot exceed $590, so they're anywhere from $0 to $590. And again, some of these deductibles will not apply for certain tiered drugs. Then once the deductible phase is over, we move into the 25/75, where the plan pays 75% and the enrollee pays 25% for their medications. Once a person meets the 2,000 cap, this is all new and it's on the next slide, they won't have any medication costs. So we're going to move to that slide next and talk about that a little bit. This is a huge change with Medicare Part D, and will um, greatly affect, impact in a positive way our out-of-pocket costs for medications. So starting in 2025, Medicare limits how much you have to pay for your prescription drugs. So let's say we have one or more medications we fill each month that add up to $500. After we fill and pay for those medications in January, February, March, and April, we have met that $2,000 cap, and our medications for the remainder of the calendar year are no cost. So that's huge. This has never been done before. Again, part of the Inflation Reduction Act and getting these Medicare costs down for enrollees and beneficiaries of Medicare. And we'll show another slide here in a couple slides, just kind of a side by side of the $2,000 cap. Yeah, and then how to get into it. The next slide is talking about another change for 2025, and that's the Medicare prescription payment plan. This is an opt-in uh, um, program so that people who maybe have higher drug costs can spread those costs out over however many months they need to be spread out. So if let's say you have $500 each month in drug costs, there would be a calculation. Um, the plan is responsible for um, determining, and then that would greatly reduce your monthly costs. You still have to pay for all your meds. You can't stop paying, but it's a way to spread the cost out over a longer period of time for beneficiaries who, again, have those higher drug costs. Yeah, so it might help manage monthly expenses, but it doesn't save money or lower the overall drug costs. It just spreads them out over the calendar year. Um, You can learn more about this at Medicare.gov by putting in your own medications and things like that to see if this is a worthwhile thing to do. I think most people who have higher medication costs would probably find this beneficial to opt into. And again, they do have to opt into it. It isn't automatic like the $2,000 drug cap. It's something you have to opt into with the plan that you're enrolled in. And I just want to say about these two changes too, and you're fine with moving the slide, that a poll was taken of Medicare beneficiaries, and about 87% of beneficiaries polled did not know anything about the Medicare prescription payment plan or the $2,000 cap for 2025. So that's a little disturbing. We definitely want to get the word out to folks about these benefits. So here's just an example again. To show how this prescription payment plan might work. So the example is Juan. He opted into a payment plan, and his first month bill is based on the maximum possible payment calculation, again determined by the plan. So what they're doing is taking Juan's $500 a month bill and calculating to spread it out over a longer period of time. And what this does is he's still going to probably get to that cap, the 2,000 cap amount, so you can enjoy both these things if you hit the $2,000 cap. So you can see that his med costs have been he's hit the $2,000 cap by May, but he's got lower costs than 5,000 or sorry 500 a month because they're trying to spread that 500 over a period of time, but he hits that 2,000 cap, and then his costs at the pharmacy are zero. Again, the calculation itself is taken care of at the plan, so they'll figure out what that is, what the monthly calculation amount would be. And this is just a side by side of the two, the two programs, the $2,000 cap and the Medicare prescription payment plan. And You can go to Medicare.gov and get really detailed information about your medications. And we understand that your medications can change throughout the year. You can go to a doctor's appointment in June and get prescribed a new medication that would kind of impact the overall formula for you. But just if you start with the beginning of the year and what medications you're currently taking, this would be kind of an example. So does this reform for Medicare prescription drugs lower my prescription medication costs for the Medicare pay 2000 cap? Yes, it does. It limits the amount you'll pay. So it'll cap it out at 2000. Does it lower my prescription costs if I opt into the Medicare prescription payment plan? No, it does not. You still have to pay for your medications up to that $2,000 cap, but they'll be spreading out the cost over a longer period to make it easier for you to make your monthly bill. Who's eligible for the 2000 cap? Anyone with Part D and in a traditional Medicare Advantage plan or standalone Part D plan. Who's eligible for the Medicare prescription payment plan? Anybody in Medicare Part D who opts in with their plan. And also, again, looking at, is it beneficial? Do I have a high drug cost? Do I have a lot of medications adding up to a lot of money at the counter each month? What do patients and enrollees need to do? Nothing with the 2000 cap is automatic. We are expecting or anticipating that there might be some bugaboos or glitches when people first go to the pharmacy in the first few months, if they hit that cap, but we're hoping not so much. And then also, it's early on. We're not even in the new year yet, but we're noticing some glitches with the at Medicare. So it'll be taken care of. They're aware of it and it'll be taken care of. So again, Medicare prescription drug plan, opt-in. It's definitely voluntary. How will I pay for my prescription meds for the 2000 cap? You'll continue to pay as you normally would at the pharmacy when you pick up your medications with the Medicare prescription payment plan. Each month, your plan will send you a bill with an amount you owe, when the payment is due, and how to make the payment. You must make your monthly payments, just as you must continue to pay your premiums for your Medicare plans. Plans can drop enrollees for non-payment, so that has not changed. Next slide. Another change in 2025, it's actually, starting in 2025, is the PrEP, or the pre-exposure prophylaxis for HIV prevention. It uses antiretroviral medication to lower your risk of getting HIV when taken as prescribed. PrEP is a highly effective combatant against preventing HIV. If you don't have HIV, but your doctor or other healthcare practitioner determines you're in an at-risk group, then they can just start you on this, if you as a patient would want to do that. It is covered, the antivirals are covered under Medicare Part B insurance, so there's that to know. And if qualified and recommended for a patient, the plan or the HIV prevention plan is going to cover up to 8 individual counseling sessions a year, including the HIV risk assessment, risk reduction, and then medication adherence. And they'll do that every 12 months. It'll also cover up to 8 HIV screenings every 12 months and 1 Hep B screening, so hepatitis B screening. If the pharmacy you go to is enrolled, can work with Part B, your out-of-pocket cost is nothing for medications, or zero for medications. That would be with your Part D, with your Medicare Advantage plan. The pharmacy must be in your plan's network for this to work. And where that can be kind of tricky is maybe a lot of smaller mom and pop pharmacies aren't enrolled in Part B. They only handle the Part D drug portion. So that's something to check into. If this were something that you would be interested in or patients would be interested in, it might make sense for them to consider switching pharmacies if their pharmacy does not work with Medicare Part B. So they can contact their pharmacy to make sure that they can bill Part B for some of these things, for some of these drugs that are Part B covered and not D as in dog covered. So it does affect out-of-pocket costs if somebody were enrolled in this program for sure, if you were at the right pharmacy that works with Medicare Part B. The next thing that is going into effect in 2025, next slide please, is the guide model for dementia care. Um, in Minnesota, we have some participants. Nationwide, there are about 390. In Minnesota, we have about 5. Um, but what this does is it's launching in July of this year, of 2025. So it's going to provide, with those participants, it's going to provide coordinated dementia care. Um, and with the outcome of improving quality of life for people with the disease, reducing strains on their unpaid caregivers, and enabling those with dementia to actually remain in their homes and communities when appropriate. So they're going to do this through Medicare payments for comprehensive package of care coordination and care management, caregiver education, and support and respite services. Um, None of the participants that are starting in Minnesota in 2025 are in the Arrowhead region. Just want to let you know that. But you can learn more. I'll put some things in the chat at the end so that you can have some of these links to learn more. This is an 8-year kind of a pilot program, and again, the folks that are providers that are participating are voluntarily participating. So it's kind of an 8-year study. Some of the ones that are going to be starting up in July of next year, sorry, I keep saying this year, is Harmonic Medical Group out of Moorhead, and then Canute Nelson, Walker Methodist, and Alexandria, the Bluestone Physician Services in Stillwater, Minneapolis Clinic of Neurology, and Life Spark Medical Group, St. Louis Park. And again, we'll get you something up in the chat if you're interested in learning more about the guide model that, again, is going to be out there and um, providing these cares for dementia patients and their caregivers uh, for the next 8 years. Next slide. So this is really just to show you where you can go to Medicare to get information for yourself. If you're on the internet and internet savvy, you can go right to medicare.gov, do your own plan compares, and even enrollment. You can call Medicare. They are open 24/7. And of course, you can call Senior Linkage Line and we can help folks compare their plan options too, and even enroll in Medicare Part D and Medicare Advantage plans. Um, we can give you information about Medigap, those true supplements out there, but we cannot help folks enroll in those because they are private and work separately from Medicare. Um, and then we have, the next slide is a brief survey. So we're going to have that too. But now let's move into questions and getting into maybe getting some of those links up for you before we go. Any questions?
Marjorie, be okay to share the slides with people after the
It will.
presentation?
And can I tell you too that if it's not already up, we will have a slightly longer version. This is a pared down version, but we have a slightly longer version that is being presented, and we have it in YouTube that we can share with folks. We can get it up on our website. So there's a longer version that was done by state staff. So it'll have more information about actually open enrollment and Medicare Advantage plans and things, and still yet have all the information about the 2025 changes. So yes, you can do that. And again, there is going to be one that's a slightly longer version that it will be available to anybody who wants to look at it. We will also be using that one out in the community and projecting it, and then meeting with folks and going over their questions after we show that presentation. I did want to mention too that for Wisconsin, um, for plan comparisons, I mean, they also have a shipper a state health insurance and assistance program, and we'll get that phone number and website up too before we leave. But yeah, just wanted you to know that there has been a nice presentation besides this one that has a little bit more meat in it about actual Medicare open enrollment and the plans that are out there and things, but still also includes the 2025 changes.
Great. There was a question in the chat. Do you know how VA care works with Medicare?
How what care does?
VA care.
Oh, yeah, sure. So it is separate also. So when people ask us, should they drop their Medicare Part B, we get that question from veterans a lot. Like, should I drop my Medicare Part B because maybe I'm 100% covered through the VA because of a 100% disability rating? And what we can say is this, is that if you needed urgent care, you would kind of maybe want your Medicare Part B. And part of the reason why people are asking that is because Part B for most people has a paid monthly premium. So what they're saying is if I can get all my care through the VA system, as a result of, what I've earned through my military service, I mean, that's great. But if you're in an emergency situation and or urgent situation, you might want to consider having Medicare too. Most people do who use VA care also use Medicare. Some people who get their Medicare prescription drugs through the VA, that's great. That's what we consider credible coverage. So people with VA coverage for their drugs don't have to worry about paying a penalty for ever for late enrollment into a Part D plan if they choose to do that down the road. Um, that goes for tribal healthcare too. That they don't. It's called credible coverage. Other people may still be covered through their or their spouse's um, employment plan. So they also are covered and not having to worry about a late enrollment penalty into Part D or into drug care. But yeah, so they do work separately. Most people, and then there's also TRICARE for Life, which is another thing for folks that they go on Medicare and TRICARE for Life. So the two don't work unless they work together. But with VA care, it is slightly different. People need to make that decision as to whether they want to enroll in Medicare Part A and B. For Part A for the hospital, there's no reason for most people not to be enrolled in that because for anybody with 10 years um, on the books with Social Security showing a work history of 10 years or more, their Medicare Part A premium is free anyway. So it's just that Part B thing that people, veterans are going to need to decide about. And in most cases, I think they generally tend to use them both and they do work separately from one another. Hopefully that helps. If not, please ask another question.
And then,
I,
Marjorie, that other one that you talked about, the longer recording, is that up on the website, or do you know when that will be on the website?
we'll make sure it's up there. We already, if it's not on our website, we'll get it there because it's already available. We have the YouTube link and we can share it with staff at the Agency on Aging to make sure they get it up there.
Perfect.
Yeah,
Marjorie, may I ask a couple of questions?
of course.
Um, First one is with the if you go off a Medicare Advantage plan and go back to the original Medicare, how hard is it to get a supplement at that point?
Yeah, if you're not in your initial enrollment window, like new to Medicare initial enrollment window, it can be difficult to get into a true supplement because they're going to do a health history look back. And even though they may say, yes, we will accept you into our plan. They may make you wait, let's say 6 months, and pay your premiums with no coverage for 6 months, or they can just deny you due to your health history altogether. And also, your costs are going to be probably higher. The best time for us to get into a true supplement or Medigap is when we're first eligible for Medicare. So that first year.
My second question is talking about the guide dementia care. You said it's not available in the Arrowhead region. Anything on the horizon that it may be, or working with care partners, or is it just not?
Yeah, I mean, right now it's not. I don't know if at the federal level they're allowing more to come on during the 8-year period. I would hope so. When I looked at Medicare.gov, and you can go to Medicare.gov and type in guide and find out as much as I know about it, really. Um, so right now there's 390 voluntary participants nationwide. I don't know if more will be coming in. I think it's probably larger healthcare systems with more options in those communities that are going to probably um, be most effective, and that's an unfortunate thing. Obviously, we um, we hurt in rural Minnesota when it comes to care for things like this. So, but doesn't mean that there won't be. That it's new, it's early, and again, we're just starting with the ones that are participating in Minnesota in July of 2025. So, but good question, and I guess we'll have to find out and continue to watch the website for things about that.
Thank you. And my last question is on the Medicare prescription payment plan. You addressed that. What if somebody doesn't pay? They can get kicked off the plan. They can be dropped. What if they pass away? How does Medicare collect that?
Right. It's pretty hard to do, actually. And they likely will not. I'm not going to say they won't, but they likely will not. I mean, obviously, there's somebody that oftentimes in when somebody passes away, there's an executor or somebody that's in charge of taking care of things like the funeral home, for instance, does things like notify Social Security that somebody is deceased, and Social Security in turn notifies Medicare, and Medicare in turn notifies their plans. If there's not a liable person that can make those payments, there's really no way to come after them. So yeah, if I were executor of a family member's estate and there was money in it, they could come after it. No estate, no money, no person, be pretty tough to do. Any other questions?
All right. Well, if no other questions, thank you, Marjorie, for presenting today. We appreciate you taking time out of your day to share this information. Um, and thank you all for joining today. You will get a post email from me that will have a link of this recording on our YouTube channel. I will also include the slides and some resources that Marjorie has too. That email might not go out until Monday, just to fair warn you, because my person who uploads to YouTube is gone for the week. So, but just, yeah, watch for that on Monday and you should have all of that information. You can always also reach out to me with any other questions that you have. You should all have my email that's in the chat as well as the emails I sent out previous to the webinar. I just wanted to mention that we do have some other upcoming webinars. In November on the 21st, we will be doing Minnesota's multi-sector blueprint on aging and updates from the Arrowhead. And then December, we are going to be doing Housing and Older Adults 101, exploring the continuum of options. And then here are ways to connect with us. But thank you all so much for joining, and feel free, like I said, to email if you have any more questions or we can help you in any way. Have a great day.
Thank you, everyone.